I'm going to welcome you today to this program that's sponsored by the International Myeloma Foundation. We'll be presenting case studies in multiple myeloma and discussing nursing implications of evolving treatment paradigms. This slide just goes over our disclosures of conflict of interest. It's the policy of the medical education resources to ensure fair balance, independence, objectivity, and scientific rigor. MER identifies conflicts with interest in its structures and content managers and makes sure that we're all providing fair and balanced material. Medical Education Resources is an accredited provider of continuing nursing education by the American Nursing Credentialing Center and Commission of Accreditation. This CE activity provides 1.5 contact hours and 1 pharmacy contact hour, which is really important as well. Don't forget to turn in your evaluation at the end so you can get that credit. This is the ONS disclaimer. ONS has designated this meeting space for our program, supported by the International Myeloma Foundation via an educational grant during the Oncology Nursing Society's 40th Annual Congress. Hooray! Yay! Again, my name is Beth Feynman. I am co-chairing the symposium with Dr. Joseph Terriman, who's an assistant professor at DePaul University. Other faculty includes Ms. soon-to-be Dr. Sandra Curtin from the University of Arizona Cancer Center in Tucson, and Teresa Maselli, who is an assistant professor of nursing and works at the Mayo Clinic in Rochester, Minnesota. The International Myeloma Foundation is a large patient-focused organization, and it has also with it the International Myeloma Working Group, which is integral to putting forth guidelines for the diagnosis and management of our myeloma patients. They have many different research projects. I do want to point you to something that you'll have at all of your desks. We have these case studies. There is a jump drive or USB or flash drive, whatever you want to call it, at each of you have it, and it's chock full of patient resources, nurse leadership board, publications. The International Myeloma Working Group has many, many different publications as well. It's all in this thumb drive, so it's a very, very valuable resource for you to bring back to your practices. The IMF is also focused on advocacy and patient outreach as well. Here is our agenda. It's 12 o'clock. We like to get started on time, so thank you for being prompt, and we really appreciate it. And we'll try to be respectful of your time as well. I will focus on the introduction, and we'll be going back and forth, Dr. Terriman and I, Teresa Maselli and I, and Sandra Curtin and I, to provide you the most updated information. Here are our learning objectives listed on this slide. As a result of this program, you will be able to describe changes in the multiple myeloma treatment paradigm. This is a very rapidly evolving treatment paradigm here, and I'd like to share that with you. We're focusing on earlier stages of myeloma. Other concepts such as minimal residual disease are also important. We'll discuss emerging therapies in multiple myeloma, their appropriate use and related patient care management. We'll also identify components of a survivorship care plan. These patients are living longer than ever, so how can you as a nurse help the patients and their caregivers? And finally, we'll employ practical tools and recommendations for long-term care and promotion of advocacy for multiple myeloma. All of our case studies will be HIPAA compliant. We are changing the names and the faces to protect the innocent, and we will be not focusing on off-label use. I'd like to introduce Dr. Joseph Terriman, who will now be presenting with me. Thank you.
Thank you, Dr. Feynman, and welcome again, everyone. We're going to start with patient number 1, Jim, and his case is monoclonal gammopathy of undetermined significance. But before that, we will do a quick review of multiple myeloma. So what is multiple myeloma? Multiple myeloma is a cancer of the plasma cells. Unlike other cancers, it's very obvious for the patient. If you tell them they have breast cancer, they know where the breast. And if you tell them colorectal, it's easy to recognize where's the colon. But in multiple myeloma, you tell your patient you're diagnosed with multiple myeloma, and they have no idea where is the cell or organ that's involved. So we're going to really go back to the very basic, and we have to tell our patient that multiple myeloma is a cancer of the plasma cells, and plasma cells comes from the B cells, and these are specialized cells that when they are through antigenic stimulation will become plasma cell, which are the most mature form of B cells. And then the job of the plasma cell is to produce immunoglobulin. And that's where the cancer is happening, is in the plasma cell. Multiple myeloma is characterized by a monoclonal production of antibodies. So in normal people like you and me, the plasma cell is supposed to produce polyclonal immunoglobulin, but what happens in multiple myeloma, there's only one type of immunoglobulin that's going to be very high. And the most common immunoglobulin produced in myeloma is your IgG. About 65% of myeloma cases will produce IgG, and that is actually expected because in normal situation, IgG is the most common antibody that's produced by the normal plasma cell. The second most common type of immunoglobulin that's produced by the myeloma cells is your IgA, about 20%. And then the last one there, 5 to 10% are called the kappa and lambda light chain. So a little trivia for you here. We name it kappa or lambda light chain in honor of the two doctors who actually made the connection that this light chain protein that was once described by Dr. Benz-Jones in the late 1800s was actually connected to multiple myeloma, and it's in honor of Dr. Korngold and Dr. Lipari. And that's why we named this protein kappa or lambda light chain. That's why it's not called an alpha or an omega light chain. So that's a little trivia. So let's begin with our case study. Jim, I'm going to put us back in the year May 2000. He was a chemical engineer, 36 years old, newly married and pregnant with a pregnant wife. He actually presented with his primary care doctor just for routine physical examination and was found to have an elevated total protein of 9.8. Now, in a primary care setting, when someone has an elevated total protein, the next logical thinking would be, where is this extra protein coming from? And so the primary care practitioner, whether it's a nurse practitioner or an internal medicine physician, would order a serum protein electrophoresis to find out why do we have an extra protein in the chemistry. And lo and behold, in Jim's case, he was found to have an M protein or monoclonal spike of 1.9 gram per deciliter. And when they did the immunofixation test, it showed that it is a monoclonal protein. It's IgG kappa subtype. So Jim was referred to a hem-onc specialist because when you do have an M protein in your blood, you're going to be suspected to have either multiple myeloma or monoclonal gammopathy of undetermined significance. So this is the workup that Jim had, an IgG of 2010, IgA of 119, IgM of 42. He had a normal CBC, and the bone marrow biopsy showed only 9% kappa-restricted plasma cell. So the diagnosis of MGUS is definitely based on the bone marrow plasmacytosis that's less than 10%. So that's why Jim is categorized as MGUS or diagnosed as MGUS. So he was told that he has MGUS, and he was informed that he will need observation every 3 to 6 months. And I'd like to emphasize that this was May of 2000, so that's about 15 years ago. And at that time, this is the myeloma panel. You have CBC, comprehensive panel, and then quantitative immunoglobulin, SPEP, and beta-2 microglobulin. I'd like to emphasize that we are now 15 years later, and we'd like to make a comparison because our title of our talk is the evolving treatment paradigm or diagnostic paradigm in patients with MGUS and multiple myeloma. So hopefully we can show that to you. So here's the current practice on the right side of your screen. You will see that, again, with the current workup, we are now incorporating serum-free light chain assay. And when we do a bone marrow biopsy now in our current practice, it is imperative that we have to have FISH as part of our bone marrow biopsy procedure. And FISH actually stands for fluorescent in situ hybridization. But here's another joke for you. One of my patients, I told the patient, you know, your FISH was normal. So I'm very pleased with that result. And you know what the patient told me? She said, I'm a fish now? So be careful of acronyms. I have so many acronyms that in the past I told the patient, you don't have crabs, so you don't have to worry. So now I have a collection of all these acronyms where my patients really tell me about this crazy reaction, like, I'm a fish now? Like, okay, maybe I should not use fish ever again. So again, but the similarity here is that the observation and recommendation is the same. Every 3 to 6 months, we're going to do a myeloma panel. And in the myeloma panel, we have to include the serum-free light chain assay.
And I think it's really important point what Dr. Tierman had mentioned about the initial workup, because they are using things called biomarkers in genomics, and not a lot of us are familiar with these words, and so I wanted to take a moment and go through the definition. So what is a biomarker? A biomarker is defined as a characteristic that is used to diagnose and monitor disease. We have biomarkers in everything. Hemoglobin A1C in patients with diabetes. In myeloma, we have our serum and urine testing, SPEP and UPEP, free light chains, and these are all very important to follow our patients, such as Jim. Genomics is the studies of genes and chromosomes and their aberrations, or the changes that have happened. What is it really important to focus on is that in 2015, we have a lot more knowledge than we did when Jim was diagnosed about the significance of these FISH testing. And what we're going to share with you is the treatment evolution in our practice of monitoring these patients. So Jim has MGUS. What is that? Again, it's this monoclonal gammopathy of unknown significance. They have a little bit too much protein in their blood or their urine in many of these patients, with a low risk of progressing to actually receiving treatment. So about a 1% per year over 40 years. Now, that risk will increase when you have more protein over time and for many other reasons. And this slide shares with you that most patients don't progress, but there is an evolving definition, as Dr. Tierman mentioned. Now, there's 3 levels. When people have an abnormal protein, such as Jim, in the blood or the urine, they're considered that MGUS, a little bit of extra cells in the bone marrow, biopsy, a little bit of protein in blood or urine, but they don't have too much. We check their blood and urine about every 3 to 6 months and make sure that they get their routine health care. The next level is smoldering myeloma. Those patients have more abnormal protein, more abnormal plasma cells in their bone marrow, but they don't quite fit the criteria for active myeloma or have these CRAB characteristics such as hypercalcemia, renal insufficiency, anemia, and bone lesions. In 2014, the International Myeloma Working Group actually changed the definition to really kind of diagnose people just before they have end organ damage. If I'm a patient with an abnormal protein such as Jim, why would I want to wait until my kidneys are damaged or my bones are damaged or I have anemia or symptoms of the disease? So what we have here on this slide is, again, the CRAB acronym that stands for calcium elevation, renal complications, anemia, or bone disease. So that's traditionally how patients were diagnosed with myeloma. Now, as of November 2014, we're including 3 additional categories: bone marrow plasma cell percentage of 60% or greater, serum free light chain ratio of greater than 100, and an MRI with a greater than 1 focal lesion. Dr. Tierman also talked about the serum free light chain assay. So we have the intact immunoglobulin level molecule that has 2 heavy chains and 2 light chains. And the light chains are kappa or lambda, and your heavy chains are typically IgG, IgA, or IgM. And what we see here on this free light chain assay, which is a biomarker test to measure disease, we see patients with kappa light chain have higher kappa to lambda ratios, and those patients would now be considered a myeloma patient if their ratio is greater than 100. Joseph?
Yes. And so for our patient, Jim, our nursing implication when someone has a pre-malignant condition like MGUS are threefold. 1, we're going to focus on patient education. 2nd, we're going to reassure the patients about the condition. And number 3 is to do some patient advocacy. For patient education, it's important to educate the patient about the facts about condition. Someone will really freak out that you're telling them that they have a pre-malignant condition and what's the rate of conversion. So that's another important component of patient education. It's important also to really inform the patient about the frequency of the follow-up, what is the rationale of doing the follow-up. And in some of these younger patients, we do need to consider informing them about their fertility and genetic options, genetic testing options. And then you also need to inform the patient that we are pretty much in the United States employer-based insurance type of settings, so they do need to keep their job in order to continue with their insurance as well. For reassurance, it's important for the patient to hear that we're going to be there and we will be supporting the patient and that we'll continue to support the patient all the way throughout the continuum of care. And then again, for patient advocacy, I think the 2 most important part is to empower our patient to always participate in healthcare decision making. And then the last one would be always to encourage them to live a healthful life. We have a lot of patient information brochure at the International Myeloma Foundation, so please encourage your patient to call the IMF hotline. Again, we even have brochures specific to MGUS and smoldering multiple myeloma, because that seems to be a very difficult topic for the patient to understand, that they have a pre-malignant condition and what they need to do and what they need to continue to monitor. So with Jim, we are now fast forward up to May of 2013. What we found with Jim, Jim had a complaint of rib pain. CBC and chemistry showed normal limits except for the elevated total protein. But over the years, what we found was that the 1.9 grams of M-spike is now about 2.5. The kappa-lambda ratio has increased to 94. And the patient Jim had another skeletal survey, showed no bone disease. If we use the old criteria of the CRAB criteria, Jim would still be a smoldering multiple myeloma. However, if we go fast forward to the current practice, if we apply PET-CT, MRI, low-dose CD, and then Jim had another repeat bone marrow biopsy, which showed 65% plasma cell, and the serum free light is now going to be incorporated in that current practice as well, Jim would be considered having active multiple myeloma based on the IMWG 2014 criteria. And Dr. Feynman will explain more on that.
Well, just as Joseph had mentioned, we are seeing a change in the way we're thinking. So for many years, until patients had identified damage to their bones, identified anemia from the plasma cell, that's when we started treatment. Well, what we're finding through research is with these newer drugs, we have pills, we have many injections and other agents to treat the myeloma. Why not find out those individuals that are higher risk of progression to myeloma and treat them early? You can see on the slide here the whole population of this MGUS patients. And again, when they progress to a smoldering or higher amount of protein, what we're finding out is that Jim, for example, would have qualified for needing treatment based on the high light chain ratio, and treating him early might prevent any damage to his body's organs. So we have several techniques available for myeloma bone imaging. We still have a historical gold standard of care, which is the skeletal survey. Most of our patients with myeloma will get head-to-toe x-rays, about 19 or 20 films, but the problem is that you need 30 to 40% bone loss before damage at any one site can be detected. Therefore, if we have suspicious lesions or we have a high question that somebody would actually have damage to their bone from myeloma, we would proceed with MRI or CAT scans. Bone densitometry or DEXA scanning is recommended for people with MGUS, such as Jim, to see if there's an increased risk of fracture, because we know patients with MGUS from research will have an increased risk of breaking bones. And if you do have a decline in bone density, then that tells you have to look a little bit closer to the MRI or the PET scan. Recent clinical trials have shown positive results with earlier treatment. Again, we recommend most of the treatment of smoldering myeloma to be in the context of clinical trials. We still have ones that are actively recruiting, but it's important to be aware of this information. We have two main trials, one from the Spanish myeloma group and Dr. Mateos, and the other from Dr. Ola Langren and his group here. Basically, what they were trying to do is say, if we give you earlier treatment, will that delay your progression to damage to the bone? And will this translate into longer survival and longer progression-free survival, or staying in remission? And both studies have been very, very positive. I again want to highlight the importance of clinical trials. The International Myeloma Foundation has a very up-to-date myeloma matrix, which is also on your little thumb drive. You can find it at myeloma.org. It lists all the clinical trials that are currently available for myeloma. Remember, phase 1 or 2 studies are earlier, smaller studies, less amount of patients. We want to use a phase 1 study to determine the maximum tolerated dose of a drug by itself or in combination with other agents. Phase 3 studies randomize to a standard of care, and many of the trials that we're going to be talking about today have all of those. So again, we have an evolution in our thinking, a change in our treatment paradigm. So in 2014, we have these updated International Myeloma Working Group recommendations for smoldering multiple myeloma. Again, we want an absence of the myeloma-defining events, none of that CRAB criteria for our patients. We also consider the serum monoclonal IgG or IgA levels to be relatively high, bone marrow plasmacytosis from 10 to 60%. But if you have greater than 60% bone marrow plasma cells, those patients need to be treated. In current practice, we have high-risk smoldering clinical trials, or again, you could observe them clinically. And at the bottom of this slide, we have all of our newer agents, carfilzomib, elotuzumab, and then some of our more established lenalidomide, bortezomib, that are in clinical development or in combination with our high-risk groups. Joseph?
So far, we have shown you that there are now changes in the definition of smoldering multiple myeloma. We're going to pick up high-risk smoldering multiple myeloma and start treating them as well based on the new IMWG criteria. We have also now learned about the myeloma-defining events, so that's an MD, so that's a new concept that we try to introduce to you. So we are trying to continue to refine our risk-adapted treatment algorithm for the new diagnosis for smoldering as well as active multiple myeloma. And then we are also refining our diagnostic capabilities as well, and you will see more in the future that we're going to be talking about minimal residual disease. Myeloma patients are living longer, and they learn a lot, and they themselves become expert of their own care. It's important that we, as the practitioner, nurses, nurse practitioners, and other healthcare practitioners should encourage our patient to participate in the decision-making process again, because they do have their own preferences. And in a period where there's so many choices and there's not one singular best treatment option for our patient, I think it is always best to get your patient's input to make the final decision. So going back to Jim, again, it's April 2014. He did show a lot of significant changes in his medical condition. I'm going to highlight that his creatinine went up to 2.3, his hemoglobin went down to 10.9, and again, his kappa-lambda ratio went up to 185 from 94, and a repeat bone marrow biopsy showed 70% kappa-restricted plasma cell, and the cytogenetics, luckily, he didn't have high-risk myeloma feature based on cytogenetic because the FISH is normal, and the cytogenetics showed also normal chromosomes of 46XY. The plasma cell labeling index is elevated at 2.0. That's a high proliferative rate for myeloma. But the sad thing here is clearly the patient's now symptomatic because the skeletal survey also showed multiple lytic lesions in the ribs, the skull, and the femur. So with that being said, if you look at all the symptoms of Jim, basically what's telling you is that the myeloma has grown, myeloma has proliferated, it's no longer indolent, it's no longer smoldering. As you can see, that is the result of the symptoms of Jim are due to the increased activity of plasma cell, the anemia, the high production of M protein, and then the bone damage due to the increased osteoclastic activity in the bone that's driven by the myeloma proliferation, and then the high blood calcium level because of the damage to the bone. When the bone is damaged, calcium leaves the bone and gets into the circulation. And then there's also the most important part is that patient gets frequent episodes of infection because of the reduced number of functional immunoglobulins. So there's more immunoglobulins, but these are non-functional immunoglobulins because they are produced by the myeloma cells. And patient will have frequent infection. In fact, the most common cause of death for multiple myeloma is infection. At the end of the day, they don't have a functional immune system anymore, and that's why they will succumb to death due to infection. The good news is that we have a lot of treatment options. Back in the 60s, the breakthrough in therapeutic was the melphalan and prednisone. Clinical trials showed improvement for the first time, response rate and overall survival rate. But then not until 1999, when the thalidomide paper was published in the New England Journal of Medicine that showed activity against myeloma cells, that heralded the whole slew of new novel agents for patients with multiple myeloma. By 2003, we have bortezomib. By 2006, we have lenalidomide. By the time we have 2012, we have carfilzomib. 2013, pomalidomide. And just this year, we have panobinostat as well. So again, we have lots of treatment options for our patients now, and I think that's the most important reassurance that we can give to our patients. The good news is that we now have developed so many new drug classification. As you can see there, we have proteasome inhibitor, we have IMiD or immunomodulatory agent. We also have alkylating agent, we have corticosteroids, we now have the histone deacetylase, which is your panobinostat, and again, the supportive therapy bisphosphonates. What that tells you is that the more drug class we have, the better it is for the patient, because we also know that multiple myeloma cells are very intelligent cells. They will develop resistance resistance to our current treatment. So the quest for newer and newer drug classification is very important to continue to improve the overall survival of our patient. And let's talk about minimal residual disease.
Yeah, so Dr. Fairman shared, I just said Dr. Fairman. I get called Fairman all the time. We're like twins, I guess. I don't know, Fairman, Terriman, whatever. Dr. Terriman had shared with us.
We do have a lot of publications together, so I wouldn't be surprised.
Anyhow, my friend to the right of me just shared some information on all of the treatment options out there. So how do you decide what is the best option? Well, there are some studies going on now that the International Myeloma Foundation is very passionate about, and it includes minimal residual disease. Now, we have other cancers, such as chronic leukemias, which to the molecular level, we can determine that this cancer is no longer detected to the millionth degree. So anyhow, this idea of minimal residual disease is using some of our less sensitive serum protein electrophoresis. We use it for routine monitoring, but it's not as specific to finding out just how little disease burden you have left. Now we have some next generation sequencing and next generation flow. These are genomic type of tests that are really telling us that the cancer's in remission. Those tests are done at specific time points on the bone marrow biopsy and are pretty well available around the United States. And you can always go to myeloma.org or call the hotline for more information. This slide shows you this MRD, or minimal residual disease assessment. It has been linked to outcomes, better outcomes. So when patients have no detectable tumor on board by these fancy new techniques, then the patients tend to do longer for a longer period of time.
All right, this is my summary slide. I guess we're doing very good. I don't even see the red light yet. So anyway,
Not yet.
maybe I should kill time. I'm just kidding. Well, what we'd like to summarize here, that we definitely have more sensitive diagnostic testing now that's available to us. Minimal residual disease is going to be the term you're going to encounter in your clinical practice as well. So keep an eye on this. In the future, minimal residual disease will be used as a treatment decision point, that if we do reach minimal residual disease, perhaps we don't need to do additional treatment to our patient anymore. So that's something that's the clinical utility of MRD in the future. Please make sure that you keep yourself updated with more diagnostic updates and therapeutic breakthroughs. There are many clinical trials now in multiple myeloma, so they're going to keep on adding up. Again, new detection methods is the wave of the future. I think we're going to improve our diagnostic capabilities as well as improving our therapeutic options for patients with multiple myeloma. Thank you.